I'm presenting Mr. X, a 53-year-old gentleman who presented with low backache and bilateral hip pain and fever for 1 month. Patient was apparently well till 1 month back when he started developing fever, which was low-grade, intermittent, without chills and rigor. There was no history of cough, vomiting, loose stools or dysuria. He had low backache, which was radiating to lower limbs. It was initially mild to start with, but the pain became so severe that he was unable to turn in bed and he was bedbound for 1 month. There was no history of any trauma or fall or tuberculosis in the past. Past history was nil significant. Personal history, he does not smoke or consume alcohol. He had loss of appetite and loss of weight, unquantifiable, for the past 1 month. Occupational history, patient initially owned cattle at home. He helped in the transport of milk and currently he was unemployed when he presented to us. On examination, his pulse rate was 88 per minute with a bounding pulse, and blood pressure was 120 by 70 millimeters of mercury. Pallor was present. There was no icterus or cyanosis or clubbing or lymphadenopathy. CVS S1 and S2 was heard. Respiratory system was normal. Abdomen was soft, no organomegaly. Prostate was examined, which was non-tender, and there was no nodules. Musculoskeletal system, he had a bilateral sacroiliac joint tenderness and bilateral straight leg raising test was positive. All movements of the hip joint, bilateral hip joint, were restricted in view of pain. The differentials we considered were, first was infections to rule out tuberculosis and brucellosis, and next was seronegative spondyloarthropathies, and third one was malignancy to rule out multiple myeloma and bony metastasis. Going on to investigation, he had an hemoglobin of 8.2, total counts were 12,900 with neutrophils of 62, lymphocytes of 28 and monocytes of 7. Platelets were 2,58,000, creatinine was 0.8 and urea was 28. LFT was within normal limits. Electrolyte showed sodium of 130, potassium of 3.9 and bicarb of 22. Calcium was 8.8 and phosphorus was 4. His serum electrophoresis and urine BJP was negative. Vitamin D levels were normal. His BBVS and initial blood cultures at the end of 2 days were negative. His ESR and CRP were 91 and 107 respectively. His prostate specific antigen was also normal. So we did an imaging. First we did an ultrasound imaging to rule out a local cause like an psoas abscess, which was negative. Then we did an MRI spine, which showed a bilateral acute on chronic sacroiliitis and bilateral patchy areas of gluteal muscle edema without any collection and moderately severe joint space narrowing bilaterally. It was reported as probably an inflammatory sacroiliitis and infection could not be ruled out. So we sent off a Brucella antigen, which was positive, which was 640 international units. The blood culture group Brucella melitensis after 3 days. Echo was done. It showed a moderate MS, AR, MR and a shaggy mass which was attached in the tip of AML with independent mobility. So the final diagnosis of the patient was complicated brucellosis with bilateral sacroiliitis with infective endocarditis. So brucellosis is one of the major zoonoses which can cause severe debilitating disease in humans. In India, Brucella melitensis and abortus are of major concern. The transmission is mainly through free roaming of animals and intermixing of livestock which happens in our country, and there's contamination of pastures, foders and stables, and due to improper disposal of abortion materials of the cattle and also due to occupational hazard. So this acute and chronic brucellosis. Acute brucellosis, it's about 50% of the cases are acute. Incubation period is about 2 to 3 weeks and worsening of symptoms occurs as day progresses. They usually present with fever, chills, sweats, aches, lack of energy, joint and back pain, headache, loss of appetite are present in majority of the patients. Arthritis, constipation, abdominal pain and sleep disturbances are also seen. Cough, testicular pain, epidermolysis, rash, ill appearance, pallor, vaginal bleeding, hepatosplenomegaly, lymphadenopathy are less common. Diarrhea, jaundice, central nervous system abnormalities and cardiac murmur and pneumonia are considered rare. So Brucella usually gets sequestrated in the reticuloendothelium system of the lymph nodes, liver, spleen or bone marrow. They can affect any one of the following organs. If they affect osteoarticular system, they can cause sacroiliitis, spondylitis, peripheral arthritis, osteomyelitis and bursitis. Gastrointestinal and hepatobiliary. Usually liver is affected even though liver function tests are normal or slightly elevated. Respiratory is most common in abattoir workers, and genitourinary orchitis and epididymitis is common in males, and there's risk of abortion or intrauterine transmission of infection in females. Central nervous system is rarely affected. It can cause meningitis and meningoencephalitis. It's affected in 5% of the cases of Brucella melitensis. So going on to laboratory investigations, culture from blood provides definite proof of brucellosis. The culture medium used is biphasic method of Castaneda. Brucella is a slow-growing organism, and cultures are rarely positive before the 4th day of incubation. Usually cultures become positive between 1st and 3rd week, and it should be kept for at least 45 days before the culture can be concluded to be negative for Brucella. So since blood cultures take a longer period of time, currently we use serological tests. It relies on the unique antigenic properties of the lipopolysaccharides. But the problems with lipopolysaccharides is that it can cross-react with Vibrio and Yersinia enterocolitica and can give us false results. In endemic areas, a large population may have developed antibodies due to the previous disease or exposure, so we can actually wrongly diagnose them with brucellosis again. So the serological tests available are either first a screening test and a confirmation test. The screening test normally used as a Roche-Bengal test, where the serum antibodies are mixed with whole cell Brucella antigen, and the agglutination is seen. Then we go on to a confirmation test. It's done either by a serum agglutination test or by an ELISA. Serum agglutination test is performed by mixing serial dilutions of the serum, usually through 1:20 through 1:2560, with Brucella antigen in test tubes or in wells of an ELISA plate. After overnight incubation, agglutination is read by the unaided eye or under a binocular. Agglutination titers of 1:160 or above is considered diagnostic. In endemic areas, the threshold value is set one step higher, which is 1:320. So this is the serum agglutination test. The last two are the controls, where the first one shows agglutination and the second one is negative. And coming from the other side, the third one shows agglutination, which is similar to the control, so that is taken as positive. So ELISA test is used to mainly discriminate between the presence of specific IgM and IgG antibodies and to roughly assess the stage of illness. These tests are very tedious to perform, hence a simple rapid diagnostic test, which is a Brucella IgM by IgG flow assay, could be very useful. The sensitivity and the specificity of the Brucella IgM by IgG flow assay for culture confirmed brucellosis is more than 95%. Going on to treatment, it can we have divided into complicated and uncomplicated. For uncomplicated brucellosis, doxycycline 100 mg twice daily for 6 weeks plus streptomycin 1 gram daily for 2 to 3 weeks can be given. Alternative to streptomycin, rifampicin can be given in combination with doxycycline at a dose of 600 to 900 mg for 6 weeks. In a complicated brucellosis, a prolonged therapy for 8 weeks is recommended. Other combinations which can be used are cotrimoxazole plus doxycycline. Cotrimoxazole plus rifampicin have been proposed, but it still needs further examination. During pregnancy, doxycycline is contraindicated. The alternative therapies available are trimethoprim sulfamethoxazole twice daily orally for 6 weeks plus streptomycin 30 mg per kg per day once daily intramuscularly for 3 weeks, or gentamicin 5 mg per kg per day once daily intravenously or intramuscularly for 7 to 10 days. Another alternative regimen proposed is trimethoprim sulfamethoxazole plus rifampicin, which is 15 mg per kg per day orally for 6 weeks. So take home points, occupational history is also important. To have a higher range of suspicion when there's a higher fever, when the disease problem is very non-specific, and blood cultures take a longer time to grow.